very much for joining this discussion this afternoon on creating fairer, healthier and more resilient post-pandemic societies. My name's Gwen Nightingale and I'm an Assistant Director for Healthy Lives at the Health Foundation. The Health Foundation is an independent charity that's committed to bringing about better health and healthcare for people in the United Kingdom. We connect what works on the ground with effective policy making and vice versa, and you'll be hearing more about some of our work shortly. I'm delighted to be joining you to moderate this session, and I know that we've got a really interesting discussion ahead. Very shortly, we're going to be hearing from Claire Moriarty and Meroonisha Suleiman about their work on COVID impacts. We're also going to be hearing from Ricardo Baptista Late and Lisa Marie Voipio-Portki about their national experiences in Portugal and Finland. We've allowed a good amount of time to have a discussion at the end of the session, so we're keen to collect questions for the panelists. If you have a question, please post it in the question and answer bar at the bottom of your Zoom screen. I'd also like this session to be interactive, so please do use the chat function to talk to other participants, make points alongside the presentation, or respond to comments made by other participants. So why are we talking about health and health inequalities today? A healthy population is one of any nation's most important assets, supporting positive social and economic outcomes for individuals and society. The pandemic and response to it have exposed pre-existing inequalities in our societies. And while life expectancy at birth rose rapidly during the last century, the latest data available suggests that life expectancy stagnated and even declined in the majority of EU member states. And there are, of course, differing levels of life expectancy across Europe. So before we get on to the presentations, we're going to start with a quick icebreaker to get a sense of the platform we are all working on to address health inequalities. And in a moment, we're going to see a series of, here's the first one, statements. And I'd like you to rate whether you agree or disagree with these statements, with 1 being strongly disagree and 5 being strongly agree. There's a star rating system. So to join in the vote, either scan the QR code and vote through that route, or you can click on the link in the chat function. So I'll just give you a couple of moments to vote. Just waiting for those lines to settle down. So we've got, it's interesting to see, we've got around about half of the audience voting in the middle, which I always take as not sure how to answer. Oh, that's just switched slightly. Actually now it's half feeling optimistic about the platform for investment. But there is some variation being seen. It's about a third who are in the middle, not sure, and then just under 10% disagreeing with that statement that a strong platform's being created. So let's move on to the second statement, which is there is wide recognition that measures to decrease health inequalities need to go beyond treatment activity and national health providers. So in your countries, what's the awareness like about the impact that education, transport, etc. has on health, and that for people to be healthy, it's more than delivering a strong health service and health system. Oh, this is looking reasonably. Oh, I was going to say it's looking reasonably positive. It's shifting as people are voting. So here we've got more people agreeing with this statement. So certainly the pandemic is providing some platform to talk about things in a different way, and that there is a recognition that about some of the wider determinants that affect people's health. but there's a spread in the responses, so that's not a view that's shared across all participants, and there's obviously some work to do to educate people about the factors that influence people's health. And then the final question is that I feel positive that the steps in place in my country will make positive changes to health inequalities. Great, thank you. And I think probably the change in distribution in this question highlights the scale of the challenge that we face around inequalities. And while there have been some opportunities that have been created around increased awareness, perhaps in some areas because of the pandemic, there are also some challenges around economics and also perhaps austerity that might influence some policy decisions that don't always have wider health at the forefront. So thank you very much for participating and joining in on that polling. I think it's helpful to see that there's variation in the virtual room in terms of how people are experiencing health inequalities in different countries, and it's useful to understand the place that we're starting from. So I'm now going to hand over to Claire Moriarty, who is the Chief Executive of Citizens Advice in the UK and was the chair of the Health Foundation's COVID-19 Impact Inquiry, and also Marinisha Suleiman, who is a Senior Research Fellow at the Health Foundation. And they're going to speak about the pandemic's implication for the UK's health and health inequalities. And just a little reminder to remember to add questions and comments into the chat. And it will be interesting, as Claire and Marinisha are speaking, to hear how your national experiences differ to the one that they present for the UK, or perhaps how they align. So over to you both.
Thank you so much, Gwen. Good afternoon, everyone. It's wonderful to be joining you as part of the European Health Forum. Claire and I will be taking you through some of the work that we have been doing over the last year at the Health Foundation. When the pandemic hit in March of last year, it became apparent very quickly that the impact of the pandemic was falling disproportionately on different groups. And so what the Health Foundation did was launch an inquiry through which we surveyed the evidence as well as conducted novel analysis to understand better the impact of the pandemic on health and health inequalities. And essentially what we did was look at the evidence to understand better what people's health, social and economic assets were prior to the pandemic and what the impact of the distribution of those assets were on people's resilience and their experience of the pandemic. And what we also witnessed through the gathering of data, both qualitative and quantitative, was gleaning a deeper understanding of the impact the pandemic was having on either eroding those assets further or resulting in new inequalities, new hardships. And the evidence review that's been collated in the report that we published in July, as well as a repository of evidence that you can access, points to recommendations for policymakers, public health practitioners, that we're hoping will provide insights into how we can build back fairer and more resilient societies. So what Claire and I will do is share some of the evidence with you. Sadly, it's not possible for us to share 9 months of data in the next 20 minutes or so, but we will certainly share some of the salient points. Next slide, please. What we will begin by doing is looking at some of the differences in outcomes in terms of COVID mortality, and to also share with you some of the insights from the report and evidence review that can help explain why it is that different parts of the UK and different groups have fared differently. Next slide. Thank you. One of the key things that many of you will be familiar about the experience across Europe and North America is that countries fared very differently during the earlier parts of the pandemic. The UK in particular fared worse in terms of COVID outcomes, particularly excess mortality. And what we saw was that the timing of lockdown and the stringency of restrictions were crucial in determining how different countries fared. We know that in the UK, there is high levels of population density, as well as regional and international travel, which really had an important influence on how the virus spread in the UK before the first lockdown was initiated, and subsequently within those areas, how the virus continued to spread in particular groups. One paper found that the timing of lockdown accounted for 40% of the differences in COVID-19 outcomes amongst different countries across Europe. Next slide, please. In addition to these geographical circumstances in terms of international and national travel, as well as timing of lockdown, one of the key things that we found was that the pre-existing health of a nation was very, very crucial in determining COVID outcomes. Gwen mentioned that life expectancy and healthy life expectancy has declined in parts of Europe, but particularly in the UK, we've seen declines in opportunities for good health, but also that in certain parts of the UK, there's been a reversal, that some parts of the country are seeing declines in life expectancy and healthy life expectancy. And some of the underlying granularity of that we can see in terms of the prevalence of certain health conditions. For example, cancer, diabetes, chronic respiratory diseases that are associated with poorer COVID-19 outcomes have seen a relative increase in the UK compared to the UK average. Obesity, that we know has a very close association with poor COVID outcomes, has been on the rise in the UK. In fact, in 2017, it was reported that the UK had the highest levels of obesity across all of Europe. And what we see is that the prevalence of some of these conditions falls disproportionately on different groups that we'll come on to in later slides. Next slide, please. One of the things that we were keen to do was to map how COVID mortality has occurred through the different groups and different population profiles. And what we see is that COVID-19 outcomes follow a very steep gradient. For those older than 65, we see that COVID-19 mortality is twice as high for those living in the most deprived areas compared to those living in the least deprived areas. We see that this gradient is a lot steeper for the working age population. Those aged 65 and younger are 3.7 times more likely to succumb to the virus from the most deprived areas compared to the least deprived areas. And one of the things that's important to highlight is that this differential impact for those in the most deprived areas is partly due to increased risk of exposure, but also due to pre-existing health. We know from some of the other work that we've done that is available in our evidence repository that those aged between 50 and 65 in the most deprived areas, in the most deprived decile, are 2 times more likely to suffer from 2 or more long-term conditions. And some of those conditions are those mentioned in the previous slides, such as chronic respiratory diseases and obesity. So you can see that there are compounding effects for those living in the most deprived areas due to underlying health, as well as opportunities for good health in terms of their living and employment circumstances. And we'll come on to that in the next slide. Next slide, please. So this is a really important slide, and there is a lot of data, so I will try and break that down for you. What it shows is the COVID mortality by different occupations, and we see immediately that there are certain occupations that have experienced greater hardship in terms of worse COVID outcomes. But what we also see is a breakdown in terms of outcomes due to the implementation of national lockdown, as well as persistence of worse outcomes following the first national lockdown. And the first thing to say is that the red bars are significantly larger than the blue bars. And what that means is that lockdown saves lives. A lot of people who were previously exposed to the virus, once lockdown was initiated, and either if they were able to work from home or they were furloughed, it meant that they were protected from exposure to the virus. But what the data also shows is that despite these measures, there are certain groups who remained exposed, who remained vulnerable to the virus, particularly those from the care and leisure sector, as well as those working in industrial occupations. And for these groups, it's partly because they had to continue to go to work, partly because of there not necessarily being safety measures being implemented in the workplace, but also due to them not having sufficient access to statutory sick pay, as well as isolation payments. And it's incredibly important that we look at this data in terms of the corollary of these different factors, and why it is that certain groups fared worse than others. What we also see is that some of these occupations fare worse in terms of non-COVID mortality, i.e. those working in the industrial sector had poorer health prior to the pandemic, and they fared worse in terms of COVID-19 outcomes also. Thank you. Next slide, please. So the previous slides show you the differential outcomes in terms of COVID-19 mortality by occupation, underlying health. And what I'll do now is also summarize the impact in terms of the wider determinants of health, both in terms of access to healthcare, as well as other services. Next slide, please. What we see is that COVID-19 poses both short and long-term risks to health. And one of the key risks that we see is in terms of the immediate healthcare backlog. When we reviewed this evidence up until May of this year, we found that there were 6 million missing patients. Sadly, this number is rising as the NHS experiences increasing backlog, and this number has gone up to at least 8 to 10 million in the last weeks. And what this means is that people are presenting late to the service, and they're suffering from worsening comorbidities, and what's likely to happen is either they won't get the service that they need in time, or that when they present to the healthcare service, they will have poorer outcomes. The other crucial factor that we looked at in terms of the wider determinants of health was the worsening mental health impact of the pandemic. And though some improvements have occurred in terms of the population's mental health, we found that those living in restrictions longer, as well as worsening financial circumstances, have had worse mental health outcomes. And this has been sustained for a significant proportion of the population. One fifth of adults are seeing persisting mental health impacts, and these are particularly worse for women, young people, as well as those living in financial precarity and areas of deprivation. Next slide, please. In terms of the longer term risks to health, those assets that I mentioned earlier in terms of employment, education, and income, we see that there's been a disproportionate impact, particularly for children in more disadvantaged areas, they've seen a loss of more than 2 months of education. And we know this is critically important for opportunities later in life in terms of employment as well as income. Although we have seen green shoots in terms of employment opportunities, there are parts of the UK that have been hit harder than others. And as we see the receding of the furlough scheme and the discontinuation of universal credit, there will be families from more deprived areas and living in parts of the country that will be hard hit. Next slide, please. One of the other aspects of the evidence that we were keen to look at is the impact of intersectionality, people's age, ethnicity, their gender, and how it is that the pandemic has affected different groups differently. And we know that disabled people, for example, have been disproportionately affected, not only in terms of COVID-19 outcomes such as morbidity and mortality, but they've also experienced worse outcomes in terms of the wider determinants of health, such as job losses, loss of income, as well as lost hours of work. And this is true also for ethnic minority communities. So when we're thinking about erosions in assets, as well as building resilience for the future, it's critically important that we look at the overall population data, but also the subgroup analysis that we've conducted. I'll hand over to Claire, who will talk to you more about lessons for recovery, as well as opportunities and risks. Thank you so much.
Thank you, Marinisha. And so from the start, the inquiry had a future focus. Our intention was not simply to document what had happened, important though that was, but also to draw from it the pointers to what would support a healthy recovery. Next slide, please. So it's important to say that we found opportunities as well as risks. The moment when people saw how people from ethnic minorities were disproportionately dying from COVID, people had their eyes opened to inequalities, was very powerful in the UK. And I think we all hope that it will be possible to build on that. I remain optimistic that we can make this translate into the right kind of recovery, but the jury is still out on that, and I'll come back to it. We saw through the pandemic that some things that we'd taken for granted, like commuting, were actually optional, and that translated into new relationships with local communities and relationships with local economies. Though we have to be honest that was another area of inequality, because we know that high streets were very much strengthened in areas where people, more affluent areas where people could work from home, much less so in areas where people were on lower incomes and continuing to have to go out to work. We saw behaviours catching up with the potential created by technology that had been available for really quite a long time. Disabled people who'd been asking for the opportunity to work remotely and had been told it was impossible suddenly found that overnight it became entirely possible to do when it was a necessity for everyone else. My own organisation, Citizens Advice, found that the overnight switch that we had to make to remote services accelerated change that we had been trying to make for some time, with the aim of providing services that were more accessible for many people. Though again, at the same time, that raises the issue of digital exclusion. So I guess nothing in this area is ever simple. Next slide, please. And we know that a lot of action is going to be needed to address the types of harms and inequalities that we've documented through the inquiry in both the short and the longer term. In the short term, tackling the healthcare backlog, we know that it disproportionately affected people with long-term conditions. Catch-up education, the gaps opened up disproportionately more widely for people from deprived areas. And protecting family finances, where we know that the impact of the pandemic was disproportionately greater for people who were in very stretched financial situations to start with. And crucially, we need to build resilience through the way we go about this recovery in a way that looks and feels different from how we've done it before. The pandemic, by its nature, gave us some really good clues to that. There's something about the extreme nature of the changes it forced on us as a society, and the fact that it affected everything and everyone at once, that speeded up effects that would normally take a long time to show through. Now, that's not to say that affecting everything and everyone meant that it had an equal experience for everyone. There was a poem that went viral on Twitter quite early in the pandemic that talks about being in the same storm, but not in the same boat. And that's certainly something that we saw. Michael Marmot, who was a member of the advisory panel for the inquiry and the architect of much of the thinking about health inequalities, has an immortal phrase: external shocks amplify existing inequalities. And COVID-19 not only provides ample evidence of that, but also lays bare the mechanism through which that amplification happens. As Marinatia's just outlined, we saw that people working in service industries on low pay were most likely to have to carry on going into work. They were least likely to be able to absorb reductions in pay through reduced hours, or to take time off to self-isolate if they came into contact with COVID. So they were most exposed to the virus. And they're also more likely to have pre-existing health conditions. So they were at greater risk of dying from COVID. And that is the truly human story beyond those shocking figures for excess mortality in people under 65. Finances are another illustration of this. In very crude terms, the poor got poorer and the rich got richer. We know that 2/3 of families on low income went into the pandemic with either either very low or no savings, and they used up those savings while those on higher incomes were able to increase them. We know that we saw a higher percentage increase in numbers of people claiming welfare benefits in areas of higher deprivation. That's not just absolute numbers, but actually the percentage by which the number of claimants went up. That's indicative of people being more likely to lose their jobs and their income in areas of higher deprivation. And we know that financial problems are associated with higher levels of mental ill health. So those same people were also at risk of higher mental ill health. So let's go back to the last recovery from a global crisis, the recovery from the financial crisis in 2008. In the UK, that's tended to be characterised as investment-led. And there's certainly some truth in that. There was a lot of money that was put into infrastructure projects as we came through the early 2010s. But what people in the UK remember from that recovery was that it was about austerity. We saw reductions in public services. We saw local government budgets come under pressure and policies that left no wriggle room for people. And again, as both Gwen and Marinatia have referred to, we saw a flattening out of improvements in life expectancy during that period. In the UK, to a degree that was seen in few other countries. And that stalling and falling life expectancy was one of the notable characteristics of the UK going into the pandemic, and has been shown to be correlated with the higher excess mortality that we experienced. So I don't think that there was any shortage of initiatives aimed at improving public health during the 10 years from 2010 to 2020. So there must have been something bigger going on that pushed the other way. And I'm kind of inclined to hypothesize that the financial crisis and our recovery from it somehow overwhelmed any initiatives that were taken on public health and caused life expectancies to stall. So my very simplistic summary is the prospect of a vicious circle. The UK went into the pandemic with high levels of inequality and low resilience, which were in part a legacy of how we dealt with the last global crisis. That low resilience contributed to our poor experience of the pandemic, and the pandemic in turn, as Marinatia has shown, has widened inequalities, making us more vulnerable to the next external shock, whatever it may be. Now that's very starkly put, but the reason is to illustrate that if we're going to rise to the challenge of creating fairer, more resilient society, we've got to break the vicious cycle, and we've got to use this recovery to reduce inequalities and build resilience. I argue that that's essential for the UK if we're going to weather the next crisis, because we know there will be another crisis along in another 10 years or so. We don't know what it will be, but we can be confident there will be one. And that means that we need a people-led recovery, not a concrete-led one. And so that means that we need a people-centred approach to how we spend money. We need to invest in early years, in education, in employment, creating high-quality jobs. We need to invest in housing, in health and social care. We need to invest in communities and in building social capital. We need a social welfare system that doesn't leave people unable to make ends meet, as we know we're going to see millions of people when the end of the special measures that were put in place for the pandemic comes next week. And it means honest discussion as a society about what prevents us investing in prevention when we know that it's better value than dealing with problems when they materialise. It also means a people-centred approach to systems so that we capture the benefits of that accelerated change that we saw, recognising that most people don't want things to go back to exactly the way that they were before. But equally, we have to be careful not to be carried away by visions of remote-only services when we know that many people are digitally excluded. Many people have an interconnection of problems that means that they do need the direct human interaction and not just remote contact. So the challenge for us as a country, for the government, but also for society more widely, is whether we're prepared to make the choices that will leave us better placed for the next global crisis. We recently marked the 20th anniversary of the terrible events of 9/11, and there was a lot of talk then about how it was an inflection point. Now, inflection points, they're interesting because they're often only visible in the rearview mirror. So what I'm interested by is, in 20 years' time, will we see the pandemic as a blip or as an inflection point? And if it's an inflection point, did it lead to better, more resilient society? Thank you.
Thank you very much, Claire and Marinisha, for that really fascinating and at times sobering presentation. I remain particularly struck by the way in which some groups were protected while others weren't during the pandemic. And the point about using this moment to seize the opportunity and build resilient communities really resonates with me. If people have got other points that resonated with them, feel free to share them in the chat. And as Claire highlighted, from a UK perspective, the pandemic certainly raised the profile of the impact of health inequalities, creating a platform for action. And the UK government's also interested in regional differences because of a different and changed demographic in new seats that they won in the last election. And this is all good news and generates momentum. But unfortunately, the practical impact of this focus on health improvement is not yet being seen. Within the Health Foundation, we're calling on the UK government to take more steps to align their policies to ensure that health is a key consideration in any department or ministry, so not just in the one that sponsors health. So thinking about the impact of education, transport, etc. on health. We're going to hear more detail from some other countries in Europe. We're going to hear more from Portugal and Finland about their approach post-pandemic to tackling health inequalities. And I'm going to turn first to Ricardo Baptista Leite, who, amongst other roles, is a Member of Parliament in Portugal. Thank you, Ricardo.
Thank you, Gwen. It's a pleasure to be with you all. And speaking from Lisbon, as was mentioned, I am a Member of Parliament, but my background is as a physician trained in infectious disease and head of public health at the Catholic University here in Portugal. And as has been very well and clearly stated previously, many of the impacts in terms of inequality have been felt across the board, not only in health, although that is our focus today, but particularly in health, and that is what I'm going to focus on, the COVID impact in my own country. Next slide, please. So, as in many countries, we had multiple waves of the pandemic. As you can see, we have a population of about 10 million people and over 1 million of confirmed cases. Some specialists estimate that that number may be actually double or possibly closer to triple, based on the number of cases that have not been confirmed due to poor testing, particularly during the initial phases of the pandemic. And truth be told, testing has always been lagging as part of our strategy. It is easy to understand as you look at the graph that I present to you that we had a terrible autumn and particularly winter. Out of the nearly 18,000 deaths that are directly related to COVID-19, more than 6,000 occurred only in January this year. So 1/3 of the deaths happened in one single month. I went back to the hospital as a volunteer during this period in my district, and I can confirm how terrible it was. And once again, when living directly in the COVID ER, one understands, especially at the most critical moments, how those who had no other alternative but to use our public NHS, that at that moment was completely overwhelmed, were left behind, in contrast with those that actually had resources to look for other responses. So this, in a way, meets what was mentioned before, due to our lack of capacity of coming from a health system that presents itself without the flexibility needed to deal with emergency-like situations as the one we are living or were living at the time here in Portugal, as many of you were across the world. Next slide, please. So you can just pass on the different bullet points and I'll speak through them. COVID was responsible for about 70% of excess mortality for the first year of the pandemic here in our country, which means that 30% of excess mortality was not COVID related, or at least not directly related to COVID. And scholars have been looking at this with particular interest, and sadly, there is a consensus that on one hand, we did have in the summer a heat wave, in the winter a cold wave, which in a way accelerated excess mortality, especially in the most vulnerable age groups. But on the other hand, the lack of response at the NHS level that was in a way refocused in terms of our resources towards dealing with COVID-19 left all known non-COVID related conditions behind. And this is something that we need to look at very carefully, especially as we fade out of the pandemic and start looking towards a post-pandemic world. What are the lessons learned to avoid that such tremendous inequalities are generated within our health system? How do we create health systems that are resilient and that are flexible enough to deal with the shockwaves, as was mentioned before? And if you look at the numbers, they're staggering. NHS activity was severely hampered by the pandemic. We had a drop of 40% in in-person visits at primary healthcare level. We're talking about less 9 million primary care visits. And mind you that in Portugal, we have more than 1 million citizens that don't have access to a family doctor out of the 10 million because of lack of resources. And many Portuguese citizens end up, around 1/3 of Portuguese citizens, actually that number is growing, and end up using the private sector, having insurances or resources to do so. So those that are directly impacted by the decrease of number of hospital or in primary care visits are those that are typically at the end of the scale in terms of their economical and social status. So the poor get poorer, as was mentioned, and the poor get also poor healthcare, as you can obviously understand. And we see other numbers here, a decrease in 1/4 of surgical interventions. We saw a drop of 40% of emergency room visits because people many times were even afraid to use our NHS, given the fear of COVID sometimes overrode the fear of being sick and needing care, which then also led to excess mortality. We saw a tremendous drop of medical exams, and this last number is quite scary in a way from a public health perspective, looking forward into the next few years, a drop of nearly 500,000 cancer screening procedures in comparison to the last 5 years, to the average of the last 5 years, which means that many of the potential diagnoses of early stage cancer that in many cases could lead to early treatment and effective treatment, these patients will appear in the National Health Service much later, probably with more severe cases. And I'm speaking about cancer here, but we, of course, could speak about many other chronic diseases coming in a place where we will probably need to invest more with less quality impact and potentially high mortality of our medical interventions. And this is something that is very difficult to measure at this given moment. But we do know, for example, that in our cancer hospitals, we have much less first diagnosis visits, which relates to the fact that we are screening less, or we had been screening less throughout this year and a half. And there's a lot of work to catch up, but the year and a half has been lost. And once again, those that actually have resources to look for other kinds of care beyond our public response, which in Portugal is the main response in terms of healthcare and is the main component of our health system, one can understand how this will mostly affect those in most vulnerable situations, be it in terms of their financial situation or social situation. And we still have not been able to pin down the direct impact, for example, in terms of mental health, but the indirect numbers are showing that also we're seeing a tremendous rise as across Europe in terms of problematic mental health issues. And this, of course, is then connected with many of the things that Claire was mentioning and Gwen about all of the other social determinants involved here. Where, of course, we see that the rise of unemployment during the pandemic affected those that had most precarious jobs to start with. And so these are the ones that are currently being left behind. Those that had jobs that did not allow digital transition are many times those that were left out of a job. And so all of these people are the ones that are suffering the most. And of course, this tends to have a snowball effect moving forward. Next slide. But not to go over time, I want to end with a positive note, if I may, because there are silver linings. And what we see here in Portugal, the picture you're seeing here is a military official. He's the Vice Admiral of the Portuguese Navy, Henrique Gouveia Melo. He led the Portuguese task force for COVID-19 vaccination. And following an initial missteps where there was a tentative of putting political leadership in front of this task force, very quickly it was understood that, as many had defended as myself, that this was a merely logistical operation, that we should put those that are specialized in mass organization and logistic skills to bring in this Vice Admiral who was trained for such activities was of critical importance with his team to organize our country. Of course, being able to work with the vaccines that we got, but making sure that those vaccines got to as many arms as possible, as quickly as possible. Portugal is today the country that has most vaccinated per capita in the world. We've passed the 85% threshold, and the impact we are seeing in the management of the pandemic locally is visible to all, as we are very quickly moving towards some normalization, so to say, of our social or the way we socially behave and interact within society, and so hopefully allowing those that survived the economic turmoil to now to grow. But I've brought this slide also to mention something additional, and I'll end at this note. The fact that Portugal was extremely successful, of course, was due to the work of this task force, but there is something underlying, and this is also a lesson learned for the future. Portugal was, even before the COVID-19 pandemic, one of the countries that had the highest compliance to our national vaccination program. We are among the countries with less registered vaccine hesitancy percentages in the world. And the trust that has been generated over decades of public health work between public health officials, health authorities, political authorities, and the people, in generating that trust mechanism, I would say, was of critical importance. When the time came, when we needed to make sure that people understood the importance of vaccination as being currently the most effective tool to control and mitigate the impact of COVID-19, we were capable of seeing that response on the ground without having to make vaccines mandatory. And this is something that I think goes to show that public health is sometimes invisible in its policies, in its actions. But whatever we do, good or bad, has consequences in the short term and in the long term. And that becomes extremely visible when the emergencies and the shockwaves come. And I'll stop there.
Thank you very much, Ricardo, for such an engaging presentation. It was really interesting to hear the practical impact that the pandemic had had on health access and the impact of existing inequalities in Portugal. And I think it highlights the different way that countries issue similar issues based on the historical picture. And it's the same with the really positive vaccination story that you tell. And it's fantastic to hear reports of such a high uptake. I'm going to turn now to Lisa Maria Voipio-Porki, who is the Chief Medical Officer in Finland. Thank you.
Thank you very much, Madam Chair. Good afternoon from Helsinki, Finland. Can I have the next slide, please? So here comes another country example from the northeastern corner of Europe. If we have a quick look on the managing of the COVID-19 crisis in Finland, we have to first say that based on the Finnish constitution, a political decision was made very early during the pandemic to take the Emergency Powers Act into force to restrict fundamental rights, e.g. freedom of movement, in order to limit the spread of the virus. And ever since, we have had a fairly strict restriction policy since June 2020 till this past summer. And as a consequence of the massive testing and tracing, to be honest, often at the cost of primary care services, Finland was able to limit the epidemic fairly efficiently. So we have had almost a record low mortality rate and a very low hospital occupancy during the whole cycle of the epidemic. And ICU capacity was never really exceeded, and other hospital care was mostly unaffected. And almost all restrictions have been lifted by the end of September due to the increasing vaccination coverage. Can I have the next slide, please? So, however, and exaggerated by the strict restrictions as was described in the previous presentations, in the shadow of a prosperous and very healthy majority of Finnish people, there are still population groups whose standard of living, quality of life and lifestyle have diverged from those of the majority. Factors behind this include, as in many other countries, education, occupational class, and income quintile. Shown here in a study in Finnish women, but later I have to say that particularly the lowest male income quintile has been lagging behind in terms of increase in life expectancy. So having said so, let me pick now one example of the impact of the crisis on health services, a little bit in line with what was presented by the previous speaker. So if I can have the next slide, please. Visits to public child and family care centers are unique and highly valued in Finland. They are preventive in nature, and there's almost 100% coverage among families in Finland, regardless of your social class, income level, and so on. So in this graph, you can see that during the crisis, the visits went down by about 1/3 at highest. And the same happened in dental care, some mental care services, and even primary care physician visits, but less so for hospital care. So this observation raises two questions to me. One, what are the consequences of this backlog, long-term health consequences? And it will take time to find out. But second, can we learn something from this experience? Do we always need to go back to exactly the same way of operations than we had before the crisis? So this is particularly important for Finland right now when we recover from the crisis. If I can have the next slide, it tells you why I'm saying so. It's because the recovery from the crisis just happily coincides with the long-awaited health and social care reform, which now will be in action starting January the 1st, 2023. And the building phase of the massive reorganization of the services is already on the way. So we think that this is actually absolutely necessary for our health and social care system to become more resilient facing future crises, whatever they will be, because our system was far too decentralized and it was almost impossible to steer. So this reform creates a huge window of opportunity of rethinking the way of providing the services and also the role of health and social care in society, because there will be a new regional election process which draws the people's attention to how we actually want to organize these services on the regional level. Next slide, please. So the fundamental feature of this reform is integration. Structural and functional integration of primary, secondary, tertiary health services, social care and rescue services under one budget, one management, and also the information systems will be combined. So this is also combined with national level allocation of resources to counties according to fairly carefully tailored population needs assessment regionally. And also data-based performance assessment and governance, which takes place in the form of a dialogue between the regions and the central government, both our ministry and the Ministry of Finance. At the same time, if I can have the next slide, please. Learning from the COVID crisis, the COVID experience, and also other pre-existing and simultaneous megatrends, Prime Minister Marin's government just recently wrote a sustainability roadmap for Finland. This was part of their half-term evaluation of the political agenda. And this roadmap defines for the first time in political language ecological, social, and economical sustainability, and describes their current situation in Finland. And it also makes a brave attempt to define political goals for the 2030s to guide fiscal decisions and investments, also for future coalition governments. I have to say that even if it sounds great, now from the civil servant's point of view, this was a difficult exercise. And it is much easier to combine economical sustainability with ecological sustainability, because they both have a price tag on them. But it's much more difficult to create a dialogue between the social and economical sustainability measures, because they don't meet each other that easily. But in any case, it's a good beginning. And in this fairly large document, there are urgent questions pointed and themes, and I copied here a couple of those. First, the just mentioned health and social services reform as a tool to balance the differences in health and well-being by ensuring equal access to services in a country like Finland, which has large geographical distances, densely populated areas, and sparsely populated areas. Equal services despite your home country. And it also draws attention to people in a more vulnerable position in the labor market that were hit hardest by the pandemic for one reason or another. So this is actually a very crucial document for the future of creating a sustainability society in Finland. And it also quite nicely outlines the role of the health and social care system in that exercise. Next slide just briefly picks some of the goals of the social sustainability described in this document. People-centered and equal services will have been secured in the increasingly diverse society. Quite an interesting phrasing. In the increasingly diverse society in the whole country. And services will be and should be implemented in an economically sustainable manner, and we consider information and digitalization as key assets in this respect. And the last bullet point is quite interesting. because the COVID crisis was a generation experience for our young people. So in this program, young people's trust in society is highly valued, and it should grow, and their participation in society should be secured. I think the next one is my last slide in this brief presentation. So during Finland's EU Council presidency in 2019, the Council conclusions on the economy of well-being in a way rewrote the concept of health in all policies. So this roadmap of our Prime Minister's government, I think, is a practical attempt or application of this thinking to support societal stability, trust, and security. And the ultimate aim is to increase this understanding of this interdependency and strengthen the link between people's well-being and economic policies, also in political decision-making, not just in our everyday lives. Thank you very much.
Very much, Lisa Maria, for that another interesting and fascinating presentation, and very helpful to hear about the plans that you're putting in place for the coming years, and that gives a really strong platform for action. So we've come to the end of our set of presentations, and we're slightly ahead of time. So thank you very much, speakers, for delivering your presentations so succinctly. And we're now going to move on to the panel discussion. We have had a couple of questions already posted in the chat, and I'm going to start by asking a couple of those. But if other people on the involved in the event want to ask additional questions, then please feel free to add them on, and we'll try to get through as many as that we're able to. So the first question that I wanted to take from the audience was around how can we genuinely level the health inequality challenge across Europe, a gap that's increasing with the privileged having the access to the best facilities and services. So this is a really big question, and it's probably as old as time, but I wondered whether perhaps the panelists could give their reflections on where a good place to start might be. So I might come to Lisa Maria first, if you feel able to answer that.
Oh, well, thank you so much. Well, the first thing that came to my mind was political will. So we battled for this reform that I briefly described for more than 10 years to make it happen. And, you know, in the end of the day, people, even the politicians, got really tired of this, of the details that always, you know, the devil is in the details. And we found the consensus that we want to provide equal services to our citizens. And I think that defining the joint political will was a key factor here. Thank you.
Thank you for that. And Ricardo, from your perspective, is there anything that you would add?
Well, I tend to agree. What I've been feeling over the years, it's been now nearly 10 years. I'm on my third term in national politics. I've also been a deputy mayor and I'm a councillor at the city level. And my experience has shown me that despite having, many of us having a very clear vision of what the reforms should be moving forward in terms of our health systems, and even beyond those, having a health-centered view in terms of governance and making sure that health is in all policies. The truth is, the ideological divide is deepening in Europe, and the only way to deal with that politically and be successful, at least from my experience, is having a it's block by block, breaking down whatever your grand vision is for the system, and then making sure that you break it down into small little pieces and negotiate those small little pieces once at a time. What I've seen and felt on the ground is that if you're able to get agreements on those small blocks, those are baby steps, but they're baby steps in the right direction. And it's much easier to find political consensuses and agreements on minor issues that have direct impact on people's lives and trying to affect the grand vision for health systems at large. The most important thing is whoever is leading the show, so to say, must continue with that wider vision to make sure that those all those different Lego blocks at the end build up into the right direction, into the final structure that you are aiming for from the start.
Claire, I know you bring experience that's much wider than the COVID impact inquiry and your work at Citizens Advice, but have you got any reflections on where to start and where government could start?
Thank you. I mean, I think one of the interesting things is it goes back to this question about whether we do most for health inequality by looking at health services and the facilities, or whether we really need to be looking at the wider determinants of health. And I think I'm increasingly convinced that while it's important not to forget about health services themselves, we need to be looking really, we need to be looking across the breadth of the issues. I think the difficulty, I mean, having spent a long time working in government, I mean, the difficulty is that you do come back to the need for investment. So there's much that can be done through structural reform, and there's much that can be done by really strong focus on delivering value for money from taxpayers' money. But certainly in the UK, when you look at the types of areas where we know that acting in these areas will make a real difference to health inequality, it's things like it's investing in early years, it's investing in education, it's making sure that there is a solid underpinning income for people through the welfare system. It's making sure that people have access to the right kind of housing, and it's very difficult. I mean, the challenge for government is always to find ways of investing in that when there will always be lots of things pulling in other directions. I guess the thing I come back to, which sort of links them to get the two together, is that there is I mean, we get into this position because there is an acceptance, an unconscious acceptance that inequality, that it's just going to be there, and then a lot of other things flow from that, and we lose the sort of sense of constant outrage, in a sense, about there being inequality, and the political will elements, I think, is the need to recover and not let go of that sense of that was very much kindled through the pandemic, of saying, how can this be happening, and then allow us to follow that thread and say, and therefore what do we need to do?
Great, thank you, Claire. And Marinisha, I wondered whether from the work that you undertook on the COVID impact inquiry, whether there was any kind of sense about public engagement in the issues, and whether that might provide any leverage for providing some momentum to tackle some of the wider determinants of health and to build that political momentum.
Thank you so much, Gwen. So that's a really good question. We did some extensive work engaging with the publics across the 4 UK nations, and what we found was that the pandemic has been an inflection point, as Claire described, for the public recognizing health inequalities, but also supporting government action. And I think one of the other things, sort of reflecting on the question that's been put by the audience, is that prior to the pandemic, then there had been calls for more joined up cross-sector working, but I think more than ever before, people working in the health sector, housing, employment, etc., they're recognizing all of these different determinants and their influence on health and opportunities for good health. So certainly there is greater public recognition, but also public appetite for action, but also that across different sectors, there is a greater recognition of the impact of health and the need for greater health resilience. So alongside what's been said about political will, as well as working in increments, I think all of these factors together do mean that it is possible for us to level up.
Thank you for that. And Ricardo, just reflecting on the points that Marinisha and Claire both made about the wider determinants of health, what steps do you think can start to be taken to pivot the discussion away from a focus around health inequalities and accessing healthcare services, which is important and plays its part, but to also have a broader look across some of the wider determinants, like, for example, having the best starts, early years, etc.?
Well, I think there are multiple ways to approach this. First of all, politicians and political leadership tend to be very sensitive to rankings and metrics. And whatever you don't measure is typically not accomplished, so to say. And so being able to measure and compare not only between countries, but also at a local, regional level, I think is of critical importance to make sure that those determinants, not only do we know about them, but we are capable of measuring them. I can recall, for example, a few years back when the SDGs were approved. I was deputy mayor of a 200,000 inhabitant city, where we transformed the SDGs into metrics and into a dashboard that were made public to make sure that we were not lagging behind on any of the 17 SDGs, and breaking down each of those 17 SDGs into local measurable metrics. So we knew exactly where we needed to invest. So that's one hand. The second hand is, although we need national policies to address it, I have no doubt that it is at the local level, at the municipal level, the city level, that we are capable of dealing with these social determinants heads on. And so it is that alliance between, of course, national programs, but then the local implementation and metric assessment that I think is critical. And I saw another question out there around the role of Europe in that sense. And I feel that if we could be capable to standardize the way we measure each of those metrics, I think would be of great use, not only in terms of value for health and looking at health indicators, but also in terms of the social determinants in its multiple forms, from jobs to education to other economic factors that we know drive to better or worse health.
And thanks, that's really interesting. Has there been much public engagement in the dashboard yet, or is it still at early stages?
Now, this was back in 2015 until I was in office, until 17, 18 at the city level. And what I can tell you is that the public engagement was great. And also the way the councillors, which are the ministers at the city level, so to say, were also engaged, because every time they submitted a proposal in the digital system, they would also have to say how it complied with one or more SDGs. And then our sustainable executive officer was responsible of feeding those proposals and their impact into the dashboard, which allowed for an assessment prior to each budgetary discussion for the following year. So actually you would see where you're lagging, and so you could redirect funds so you could try to catch up. But this is just comparing within one city. If every city were to do something that similar, or every region, then we could not only compare among ourselves, but also compare among others, creating healthy competition. Just to give you an additional example, for example, when it comes to climate change and energy efficiency, the city where I was working at was actually always in first place nationally when it came to any form of awards or recognitions in that field. But when we looked at the SDGs for energy efficiency, we were down to 60% compliance back in 2017, which was the lowest among all SDGs. And so it goes to show that awards and recognition sometimes are not properly sustained on concrete data, on the reality of things. And I think we need less to fool ourselves with these kind of recognition. And we need to work on more concrete data, to use that data as a carrot to move us in the right direction.
Thank you for that. Within the UK, our Office of National Statistics have recently launched a health index, which is a basket of indicators that capture measures of health that includes indicators on the wider determinants at national and local government level. It's still very early days, so various institutions are working out how best it can be used and how it can drive progress. Lisa Maria, I see you've got your hand up. I wonder whether you're going to answer the question that I was going to ask you, which was whether there was anything similar in place in Finland.
Well, thank you. Just reflecting on what Ricardo just said. So I briefly said that part of our new reform is the reallocation of the funding of the health and social care system, which includes also public health. and social support. Not all welfare benefits, but many of those actually. And this reshuffling of money and public power is the biggest change that we have ever seen during the 100+ years independence of the country. And so how do you now divide or define how much money the state should give to each county, 22 of those, instead of the municipal autonomous tax-based funding that we used to have? So this is really an interesting exercise and has been greatly supported by THL, our National Public Health Institute, which has created a matrix of measures up to 400, but there is a small set of those used for the evaluation of the people's needs in that county. So what are these population needs? How do you define the needs? Of course, some of that is simply what care that has been delivered, how much that has actually costed the municipalities within that county. But there are quite a lot of determinants of which you would call the social determinants of health, and so on. And I sort of would like to see what kind of political debate on the municipal and regional level we will see when we will have the first elections in January next year. And money, of course, is the big issue to be debated. Why do we get money? Why do we lose money compared with what we usually used money during the reform? So this is an interesting window to view what people think and what the politicians think about what we should actually fund, what kind of actions we should fund. Thank you.
Thank you for that. And I think there's another question that probably builds on where this discussion's going from the audience. I'd be interested to hear the panelists' views around how you embed that political will to invest in what is a long-term issue when the mandate to rule is often shorter and it will take longer. And there was a particular question about the prospect of having a joint European effort around inequalities. And so I suppose I'd like to ask the panel, how realistic does it feel that this is an issue where coming together across Europe might drive progress more quickly? I don't know who's keen to answer first. I'm just trying to get a sense from the body language. Ricardo, shall I come to you this time first?
All right. Well, starting with the first one, because it's a classical question, which could apply to public health as it could apply to climate change. How do we convince policymakers to act based on something that will probably have impact in future political cycles and not their own, where the costs are now and the benefits are in the future, so to say. And many times, many don't believe that those benefits will come. And to deal with that, there is no magic answer, but at my university, we developed a tool that I think has had some impact based on our experience with hepatitis C. What we did was, as a cure was developed for hepatitis C, we developed a policy tool that we transformed into an app, where basically everyone could see the impact of the current policies in their country. And using the app, we gave people the power of being ministers of health, where they could actually change the policies, and the app would automatically calculate the health outcomes of those changes. So we called it a policy calculator. And so this kind of modeling, but using it in a user-friendly way that any politician who has no background on science or health, but just understands, if I do A and B, this will amount to C and D, but if I do E and F, it'll amount to something different. And understanding those different impacts, it's shown to be extremely effective, because not only are politicians more keen to invest in something they can somehow understand what it will lead to, but they have something to show for, because they can say, look, I've invested, and this is where we're going to be 5 years from now, 10 years from now. And these kind of tools are much more effective than just saying, listen, if you do this, this will lead to a better situation 10 years from now. you need to give them the power to make those decisions, especially because many times it is not possible to do, due to lack of resources or for some other reasons, to do everything that we as scientists want to present. And many times from a scientific perspective, presenting to policymakers, many times we do not do those kind of projections. Another important aspect is intermediate results. You know, saying that something is going to have impact 10 years from now, we need to show what that means 1 year from now, 2 years from now, so that we can constantly assess that the investment that we are making will have impact, that we are going in the right direction with that investment. And that makes it possible for the people that are accountable for political power, be it a government at the governmental level or others, being able to say, listen, we made this investment, we're not where we want yet, it's going to take 10 years, but as you can hear, 1 year ongoing, we've hit our first milestone. And that is something from a scientific perspective, when we defend these kind of investments, we need to make sure that we are capable of presenting them in a way that they can be used from a political management perspective. In terms of the merits of a joint EU action, I think I go back to the need for standardization that I already mentioned before, but also speaking more specifically now on the pandemic, I think it is very clear for everyone that Europe needs to agree on a health emergency act dealing with biological cross-border threats. We are not prepared. We weren't prepared before. Ebola was our first sign of threat. We did not prepare ourselves. Then came COVID-19. We saw that dealing with the cross-border issues was a nightmare. And at the end of the day, we continue exactly as we were in terms of legislations and regulations. I think that, that there is a very short window of opportunity here while people still remember COVID-19 to make sure that we fix the lack of laws and regulations to make sure that we are better prepared. We cannot wait for every time there is emergency to sit and agree unanimously 27 member states on important decisions that sometimes a difference of hours in those decision-making processes can lead to tremendous negative impact on populations across the continent.
Thank you for that answer. Claire, I wonder whether you have any reflections based on your previous experience across government and elsewhere.
Thank you. Yes, just to add a few reflections. I mean, I think that this is absolutely the 64 billion, possibly $1 trillion question of just how it is possible to get over a natural tendency to work to short cycles. And I mean, within the I worked for many years within the Department of Health in the UK and to some extent in the NHS, and even within the NHS, there's a constant pull towards investing in acute services. Even though we all know, because there was lots of research to show that public health interventions and investing in primary care and social care are actually have a bigger impact. But there is just that very, very strong pull. So just thinking about just a few things. So one is, as Ricardo was saying, I think the importance of a burning platform. So if you look at climate change and where we have now got to on net zero, arguably considerably later than we should have done in every country, but there is this sense that although this is not something that's going to produce an immediate result, certainly within the UK, there is a recognition that there needs to be massive public investment and private investment and the coming together in order to tackle climate change. So there is that question of how big a problem does a problem have to be before it creates that burning platform. One of the things that is very interesting within one part of the UK is in Wales, they have passed something called the Wellbeing of Future Generations Act, which essentially, again, it anchors back to the SDGs, but it is a way of putting the necessity of thinking long-term and thinking about what those long-term impacts will be and making it a requirement. So public authorities have to demonstrate, rather in the same way that Ricardo was talking about, public authorities have to demonstrate that what they're doing is consistent with taking that longer-term view, thinking about long-term sustainability, which I think it's interesting as a mechanism to kind of to flip the political process out of the natural cycle it would fall into. It's also, I mean, I think actually the SDGs are a very interesting example of that kind of massive joint effort. It's not necessarily the joint effort at the process end, but certainly the way in which the SDGs have been taken by every country, and they're being taken forward. I'm sure there's something promising there to pull from. And then the other thing which I was endlessly fascinated by as a sort of a senior official was why we do so little learning from the past. We certainly in the UK we go through a constant cycle of seeing a policy problem, coming up with a solution to address it, implementing it, finding that it doesn't produce the result we expected, but then not going back and saying, well, why didn't it produce the result that we expected? What else was going on? What are the bigger drivers and incentives that we need to take into account? And the example I gave of kind of austerity meets public health initiatives is an interesting one. Lots of public health initiatives taken, actually we ended up with stalling life expectancy because there are other things going on. And I think somehow trying across government at local level, at national level, across ministers and officials, really kind of trying to embed that habit of looking at what's happened and using it to help understand. The past gives us the future, and if we start by understanding that, we can begin to change things.
Thanks for that, Claire. Lisa Maria, I think you wanted to come in on this point.
Yeah, just very briefly, if I understood the question correctly, so it's aimed at inequalities being addressed through comparing states or regions with each other. And that's, of course, a very sensitive issue. And if I take my European Observatory hat on me, so I would like to pay attention to the state of the health in the member states report series, which is sort of a very polite way of addressing this between member states. And just as Ricardo said, so if we have a very clear scientific question, scientific evidence to address the health issue, like the hepatitis C issue, then it's always easier to promote even the small steps. In this case, not maybe necessarily always the small steps, but when it comes to really deep societal issues, then it's of course it's a question of the mandate of the EU, for example, compared with the mandate of the member states. When it comes to political issues and about their societal structure and the political priorities that they set. But also here I'm a little bit optimistic. I think that if we can provide solid evidence in long term, as the one example that I showed you, which compared demographic tendencies in Finland over the 20, 30 years, and nothing happened, no progress was made. So I think that is also an asset that gradually, if we can show that inequalities actually make nations weaker, so that would perhaps help and be a solution. Thank you.
Thank you very much for that. And we're coming towards the end of this really interesting discussion. And there are two broad themes that we've still got in the questions. With the first one, I'm going to come to you, Marinisha. One of the points that's come through is an earlier plenary discussion, a new social contract was discussed. And how do you feel about how a wider approach like that could be used to tackle inequalities? Could a new social contract help? From your experience, what are the sorts of things that it might include if it's helpful?
Thank you so much, Gwen. So I did have some reflections on the previous two questions that may actually link to this issue of a new social contract. And I think a lot of us have recognized in the last 18 months that there's a real opportunity when we think about the role of public engagement, public voice, and the public's role in demanding action on inequalities. And never like before have we seen the arrival of science and scientific data in our living rooms, people talking about viruses epidemics, statistics, and having a level of literacy that was not prevalent before. And that raises an opportunity in terms of the role of that public understanding, public literacy, and education and engagement within democratic societies. And that may very well lead to shifts in that social contract, both in terms of what's demanded by the public beyond public health services in the way that we've previously recognized, away from just acute care to the types of services that have been described by other panelists in terms of the social determinants of health. The other is about the role of data more broadly. You know, what is the opportunity in terms of Europe-wide action, and even what it is that publics may demand of their leaders in terms of greater collaborative action. And again, unlike ever before, we've seen the impact of shared evidence, shared experiences on unveiling the disproportionate impacts of the pandemic on particular groups. A key example of that is the impact of the pandemic on ethnic minorities. We know this through data that's been shared across Europe as well as America, that's led to political action on bespoke data collection around particular populations, as well as the setting up of, for example, in the UK, of the Race and Health Observatory. So science literacy and education is a crucial mechanism through which we will be seeing a change in this social contract, but also in the sorts of things that are demanded by publics. But I'll stop there because there are lots of panelists here who will be able to add more to that.
Well, thank you for that, Marinisha. And I think some of that strays into one of the other questions that was asked about the about how we can mitigate health inequalities in systems that don't have fully realised universal health care, and that sharing of information and evidence is one way in which that agenda can be taken forward. Lisa Maria, are there any final points that you would like to make?
Thank you. I would just very much support the previous speaker in her points that this is, health literacy, education, sharing data, sharing evidence. That also is a demanding task to the scientific community to step down from their ivory towers and share the evidence with people. That's one of the take-home messages of the COVID crisis. Thank you.
Thank you. Ricardo?
I couldn't agree more, and I'd just like to add that based on what was discussed before in terms of country comparison, I think there's an effort that needs to be made in terms of getting more independent data, in the sense that we have an overdependence of national governments actually controlling the data that then is sent up to multilateral bodies that then publish that data. And I think that an independent assessment of what is being shared is important, as would be to have more timely information, in the sense of having more real-time information. Just to say that what Lisa Marie was saying about making sure that scientists are capable of transmitting their information more effectively. I run an NGO called Unite, which is a global network of parliamentarians committed to ending infectious diseases. And what we are seeing is precisely the need for scientists not only to transmit more effectively, but adapt their language and the way they present to the needs of those policymakers. And that's something at our NGO that we're always happy to support, bringing together real world parliamentarians and congressmen and women and senators to work with scientists to develop the language and skills needed for that bridging of information.
And Claire, were there any final brief points that you wanted to make?
Just very, very quickly, I think what comes out of those last interventions, I'm left thinking about communities and the local level, and how much more we can do when we really try to create the kind of connections that people were talking about between politicians, with academics, but particularly to be giving communities their voice and really listening to what citizens are telling us.
Well, thank you very much. Thank you to all panelists for your presentations and your contributions. It's been a really interesting debate, and I'm sure we could have gone on for much longer. Thank you also to Cara for helping behind the scenes, and Louise for helping me get through most of the questions. I hope that everybody who has been participating has enjoyed the debate as much as I have, and enjoy the rest of the conference. If you're more interested in finding out more about the Health Foundation and the work that we've done on the wider determinants of health, we've got a whole host of information and evidence on our website. So thank you very much, everybody.